I just came back from the ECTRIMS meeting, and we had an exciting release of data on Ufatumumab, a new B-cell killer which is injected once a month. In this video, I'm going to review the data with you. So if you'd like to learn about it, don't turn away. That starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. I just came back from the ECTRIMS MS meeting. It's the European Committee of Treatment and Research in Multiple Sclerosis. It was in Stockholm, Sweden. I'm actually in the airport in Amsterdam as I record this, trying to get home. And I took pictures, you're not supposed to, of one of the most exciting lectures there, where they released data on a new B-cell killer, Ufatumumab. So in this lecture, I'm going to share with you the results. Let's jump in. When I went to ECTRIMS, I may have taken pictures of all the slides for the Asclepios trial, and I'm going to walk you through them right now. The first slide we're going to look at is the study objectives and the key endpoints. And this is really trying to lay out sort of the gist of what the trial was trying to accomplish. So the primary objective of the trial was to compare the efficacy and the safety of two different products. The first one is Ufatumumab, and it was being compared against Teriflunomide. So what does that mean? Ufatumumab is a B-cell killer. It's in the same family or class of drugs as ocrelizumab and rituximab. This particular B-cell killer is different because those first drugs I mentioned are given through the vein, IV. And this is given as a self-injection under the skin, subcutaneously, once a month. And that's Ufatumumab. So in this trial, they're comparing Ufatumumab against Teriflunomide, the code name for Aubagio. Aubagio teriflunomide is a once-daily pill. The primary endpoint of the trial was annualized relapse rate. So when the people entered into the trial, they were randomly assigned to take one of those two drugs. And I'll go over more of that in a second. And they were trying to see which group of patients had more attacks or relapses. Were they in the Ufatumumab group or were they in the Teriflunomide group? That's what they were trying to sort out. Now you see on the slide, there was a bunch of secondary endpoints, meaning the first thing they tried to accomplish was analyze relapse rate, but they also wanted to look and see if the two drugs would have a difference in their ability to slow down disability progression. And you can see they looked at 3-month disability progression, they looked at 6-month disability progression. And disability progression means that on a given time point, you develop a problem with your exam. So you have a limp with your walk, or you can't see as well, or you're less coordinated. And then at a second time point, 3 or 6 months, you've maintained that deficit. And we call that confirmed disability progression. You also see on the slide, they were looking at confirmed disability improvement, which is way more exciting. They were looking to see if people in either group had more improvements, meaning your exam got better and it stayed better for a period of 6 months. Now, there were also secondary endpoints looking at the MRI, and they looked at gadolinium-enhanced lesions, they looked at new or enlarged T2 lesions, and they looked at brain volume. I also want to point out something cool. This trial looked at neurofilament light. Now, this is a blood biomarker, and as the neurofilament goes up, you're not doing as well, and as it goes down, you're doing better. And so in the trial, they were comparing, did the group on Ufatumumab do better or worse with neurofilament light levels compared to Teriflunomide? This slide reviews the study design. In other words, how do they set up the experiment? And there were 2 identical trials running simultaneously. You might ask yourself, why not do just one big trial? Well, there's a couple reasons. The FDA and the EMA want more than one trial to demonstrate efficacy of a medication. And so the manufacturers and the scientists plan for 2 trials at the same time. Also, there's a good scientific reason. When you grab a group of patients and put them through an experiment, that's a sample. It's not all the patients in the world, it's just a sample of patients. And if you find a result, it's not necessarily representative of the whole population. So if you grab one sample and do an experiment, and then you grab a separate group of patients, another sample, a separate sample, and you find the same result, it gives credence that the effect that you found was actually better representative of the whole population. Hence the reason they do 2 simultaneous trials. Now, when you look at the slide, what you see is this was a very eloquent clinical trial design. And I'm sorry for the noise, I'm actually in an airport while I record this. And the way the trial was set up, everyone in the trial was randomly assigned to either take Teriflunomide, the pill, or the study drug Ufatumumab. But it was hidden from them. They were blinded. And in fact, the way they did it was kind of cool. Everyone in the trial took a pill. Everyone in the trial took a shot once a month. Half the group, the pill was real and the shot was fake. The other half of the group, the pill was fake and the shot was real. And that's called a double dummy design. And that's a very good design. Also, the patients didn't know which allocation they were on. And the doctor evaluating the patient didn't know. And that's called double blind. And so this was a prospective trial, meaning we're going to put them in the groups and then watch them as they move forward. Double dummy and double blind, a very powerful clinical trial design. We can see here that we were testing relapsing patients. They were able to have a disability up to before they need a cane. So patients with a cane or a walker or a wheelchair were not permitted in the trial. The ages were 18 years old to 55 years old. And you might say, well, why? There's ethical issues in testing children. And so all adult trials start at 18. And the reason they look at before 55 is for statistical reasons. And so that's the population they're looking at. And they had over 900 patients. All of them had a relapsing form of MS. And you see in the trial, you can see where the injections were given. Now, all the patients, whether they were on real drug or fake drug, had 3 loading injections, and then it was once a month. And you can see that listed there for you. In this slide, we see where the patients came from. And this was truly 2 global studies. They weren't done in just one country, they were done throughout the globe. We see that a quarter of the patients came from Eastern Bloc countries, which is something that we've only seen in the last maybe 5 or 10 years. Before, most of the trials were done in the United States, Canada, and in Western Europe. Now, this slide gives us more details about the study population. Who were the relapsing patients that were enrolled into the trial? Some of this we went over just a second ago. We're talking about both men and women who have relapsing MS, ages 18 to 55. They had to meet the classic criteria for MS. So this wasn't just I think they have MS. They actually met the McDonald criteria. And they had to have a disability from 0 to up before they need a cane. So patients with a cane were not allowed in. I want to point out that the patients had to have active disease. And you can see on the left-hand side of the slide that in order to get in the trial, they had to have 2 attacks in the last 2 years or 1 attack in the last year. And they had to have MRI that showed at least a gadolinium-enhanced lesion. The reason they did this is because if you have a bunch of patients that haven't had attacks in years and years, you could enroll them in the trial and watch them for years and nothing happens. You're more likely to see a patient that comes into the trial with active disease have activity in the trial. And that might sound weird, but you're doing an experiment where you want to see if you can find a change. And so you're selecting patients that are likely to have disease activity. On the right-hand side of the slide are the exclusion criteria. So if patients had any of those things, they weren't allowed in the trial. This is a very important slide. And it tells us about the characteristics of the patients that were enrolled in the trial. Now remember, when these relapsing patients came in the trial, they were randomly assigned to be on real Teriflunomide, the pill, and they took fake shots, or real Ufatumumab, the shot, and then the fake pill. And they were randomly assigned. There's a statistical theory that if you randomly assign people into 2 groups, you're going to have group A with about the same age as group B, and group A with about the same number of women in the trial as in group B. And this slide makes sure that that's true. And it was a balanced trial. You can see the section in red, and this is some really important information. On average, the people enrolled in this trial had had MS for 8 years. And that's a bit longer than we're used to seeing with other modern trials, where they've only had MS for maybe 5 years. Also, 60% of the patients in the trial had previously been on disease-modifying therapies. And in other modern trials, it might be 60%, it might be a little bit less, like closer to 25. you can see that they had all had about 1.3, 1.2 attacks in the year preceding the trial. And so that's a very active population. And the average disability scale was almost a 3. On that EDSS of 0, it allowed up to 5.5. An EDSS of almost 3 is a moderately disabled individual. So this is important information. I also want to point out, when you look at the contrast, that 60% of patients, I said that backwards, that 40% of the patients had contrast-enhancing lesions on their MRIs at the baseline, at the first scan they did for the trial. Again, demonstrating that these were an active group of patients. Here we see the patient disposition. In other words, when we enroll a patient in a trial and they're randomly assigned to either be in one group or the other, what happened to them? When the trial ended, how did it shake out? And this is an important slide also, because if, let's say, 50% of your patients quit the trial, then you might not really be able to interpret the experiment. What we see here is that this was a pretty typical MS trial. Let's look on the left-hand side. That's the first version of the trial. And you see how 1,277 people were enrolled, and they were randomly assigned to receive Teriflunomide, the real pill, and then a fake shot. That's kind of in gray. Or the Ufatumumab, the real shot, and then the fake pill. And it was split 50-50. And then as you look down, you can see what happened to them. At the end, that line that says completers is the line that we really want to pay attention to. And we see that on average, 81-82% of the patients finished the trial. That's to be expected. That's not impressive, and it's not bad. And so it kind of gives us an idea that, yep, this trial went the way that we would expect it to. It's also important to point out that it wasn't disproportionate. So the same percentage of patients quit out of the pill group as did the shot group. And that's another important thing to note. Okay, now we get into the results. So this might be the money slide, if you will. And remember, the primary outcome of the trial was to compare groups of people with relapsing MS on Ufatumumab and then a fake pill against the group that were taking Teriflunomide, the real pill, and a fake shot. And the primary outcome was to look at the annualized relapse rate, or on average, how many attacks did the group have in a year. And what we see here in both trials, when you look on the left and the right-hand side, is that the patients that were randomly assigned to take the Ufatumumab, the B-cell killer, which is in blue, they had 50% less attacks than the people on the pill, Teriflunomide. And on the right-hand side, you see in the second trial, it was actually 58% less attacks. So this is a very robust result. If you were randomly assigned to take the shot, you had half the number of attacks as the people that took the pill. And this is highly statistically significant. And so this trial met its primary endpoint. Now I'm going to walk you through the secondary endpoints. Remember, when we started the conversation, we talked about confirmed disability progression or confirmed disability worsening. And you see the data has been pooled together. So we're combining all the information from the first study and the second study into one group. On the left-hand side, we're looking at 3-month confirmed disability. So your exam gets worse, and when you check the person 3 months later, it's still worse. And what they found was the people that were taking the Teriflunomide pill got more worse than the people that were on the shot, the Ufatumumab. And that was a statistically significant difference. And when you look at the 6-month definition, so you get worse on your exam, and 6 months later you're still worse, same thing held true. The data was statistically significant. The effect size, meaning how much difference, was in the 30s. And this is a positive result, but it's not a robust positive result. It's a good result, not a great result. The annualized relapse rate, the last slide, that was a great result. And so that's something that I want to call out. I also want to point out that Teriflunomide, the drug that they compared it to, Aubagio, is not amazing. It's not remarkable at decreasing attacks, but it's pretty good at decreasing disability. And so maybe that contributed in part to why we saw a really robust result with the annualized relapse rate and a less robust result with the confirmed disability worsening. Now, this is a much more fun endpoint. This is looking at confirmed disability improvement. meaning your exam got better, and then 6 months later it was still better. And what they saw here was a trend that favored the Ufatumumab. So it favored the shot over the pill, but it was not statistically significant. So it didn't reach the level where it couldn't just be explained by chance. And this is a little bit different than some of the other highly effective drugs like ocrelizumab or alemtuzumab, where we saw that there was a statistically significant difference. And so they missed the mark on this, but the trend is in the right direction. Now we turn our attention to the MRI. And remember, I shared there were a bunch of MRI endpoints. And here we're comparing follow-up MRIs done in the patients, and we're looking at new contrast-enhancing lesions. So when we got a follow-up scan, how many of the patients had gadolinium enhanced on their MRI? And what you see in gray is the teriflunomide, the Aubagio arm, and in blue is the Ufatumumab arm. And very clearly, the folks that were taking the shot had way, way less contrast enhancement compared to the pill. So this was a very robust result. And this is similar to what we saw with ocrelizumab, with a very robust result. This suggests to me that B-cell killers are really good at shutting down gadolinium on the MRI. Here we're still looking at the MRI, but instead of looking at the contrast enhancement, we're just looking at the white spots, the T2 bright spots. And again, the trial favored the people taking the Ufatumumab shot. It wasn't as robust as the contrast-enhanced lesion, the slide I just showed you. It was still a really positive result. And again, this mirrors what we saw with ocrelizumab, another B-cell killer, where these B-cell drugs are really good at improving the MRI. Now here we're looking at brain volume loss or brain atrophy. Now all people over the age 18 have programmed brain shrinkage. Just like your skin gets thinner as you age and you get shorter as you age, your brain shrinks as you age. But in MS, it can happen upwards of 10 times faster. And we look at the MS drugs to see if we can slow that down towards normal. Here, they missed the mark. They were not able to demonstrate that the Ufatumumab delayed brain volume loss or slowed brain volume loss compared to teriflunomide. And this is kind of a miss. It was a disappointing thing to see. We were able to show brain volume improvements when we looked at other highly effective drugs like ocrelizumab and alemtuzumab. I also want to point out that teriflunomide, Aubagio, which is the gray line, is very good at delaying brain volume loss. And so the comparator that this trial used happens to be very good at that, and maybe that's in part why we didn't see a difference. Nonetheless, I was a little bummed about this finding. Now, those of you that follow my live streams on my channel have heard me talk about neurofilament light chain before. Neurofilament light chain is a blood biomarker, and it's not available clinically yet, but it's being increasingly used in research, and it's kind of awesome. When you have brain damage and the axon breaks, so the cell, the neuron breaks, it leaks out the scaffolding inside, it kind of like spills the guts of the cell. And it spills it into the spinal fluid, which then gets into the bloodstream. And you can draw blood and you can check the level. So the more brain damage, the higher the level. The less brain damage, the lower the level. And what we see here is that the people that took Ufatumumab, the shot, their levels dropped a lot compared to taking the pill Aubagio or teriflunomide. And this would suggest that there's a superiority as it relates to neurofilament light chain in taking the shot. I think this is a very robust result, and I'm really excited that we're now talking more about neurofilament light chain. You're not going to see an MS trial in the future that doesn't test this. They're all going to test this. And I eagerly await an opportunity where we can use this blood biomarker in clinic. I may do an entire lecture just on this neurofilament light chain in the near future because it's really cool. So that concludes all the efficacy data. Now we're going to talk about the safety and tolerability data. And AEs stands for adverse events. So if a patient in the trial had a problem, if they got sick, it has to be reported. And they compare to see if there's more problems in the teriflunomide arm, that's the pill in the gray, versus the Ufatumumab arm in the blue. And so you can look down that list. And what we find is that there really isn't a big difference between one group or the other. nothing really stood out. And that's a reassuring finding. So we weren't seeing any particularly crazy signals. Now, this next slide is still looking at adverse events, but it's looking at serious adverse events. Serious as deemed by the primary investigator. So, for example, an infection wouldn't be included here. An infection that required hospitalization would be included. And so these are much more serious adverse events. And you can look left to right and kind of compare them. One thing I want to point out is we didn't see a cancer signal. When another B-cell killer was studied, ocrelizumab, there was an initial question mark about breast cancer. And we now know that there really isn't a breast cancer signal. And so I was very happy that in this trial we didn't see a cancer signal. And I think that gives credence to the idea that as a class, B-cell killers are not really increasing risk of cancer. So I thought this was a reassuring slide. Now, Ufatumumab, the study drug, was an injection. And patients took 3 injections under supervision in the trial, and then they were able to self-inject at home once a month. And this is looking at injection reactions. And we see that there's initially some injection reactions with that first injection, and then it kind of comes down. A couple things about injections. I don't like injections. When I was coming up through the ranks, all we had available to treat MS were shots, the interferons and Copaxone. And over time, people don't tend to tolerate shots very well. And there's a statistic that bothers me, that with interferons, if you look 2 years after patients have started shots, only 40% of people are still taking them the way they're supposed to. I followed patients that have been on Copaxone for over 10 years, and they can develop injection fatigue. So even though I'm very happy to see that there weren't a lot of injection reactions, I have kind of negative feelings about asking someone to take a shot. So if you've made it this far in the video, and I want to ask you a favor, in the comments, tell me how you would feel about injecting yourself once a month. I'd just like to kind of hear your thoughts. So this is the summary slide from the presentation. And in both the 2 trials, they found that Ufatumumab outperformed Teriflunomide. So the study injection outperformed the pill as it was related to relapse rate in a really robust way. It also improved disability worsening, but not as big of an effect. It was not able to show an effect with confirmed disability improvement. It was not able to show an effect with brain volume. It did clean up the MRI very nicely. We saw very robust results as it relates to decreasing contrast-enhancing lesions and new T2. And it showed that it was able to lower neurofilament light chain. Now, overall, there was a very positive safety profile, so we didn't see any scary stuff. And that's really good news. There you have it, guys. I bootlegged slides from the ECTRIMS lecture and brought them to you so that I could share the study results. I'm curious if you liked this presentation. I wanted to be able to share with you the way the scientific data was presented. My name's Aaron Boster, and again, thank you for learning about MS with me. If you'd like to learn more about MS clinical trials, click that playlist right there. And I have a bunch of videos on different MS disease-modifying therapies. YouTube thinks that you would love that video right there, so you might want to check that out. And if you haven't yet subscribed to the channel, I would love it if you did so. Just click that circle with my face in it. Go ahead, click my face.